Hello, my name is Dr. Roger Henderson and I'm a GP in South West Scotland, and I also co-host the GP Notebook study groups. Welcome to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now you can find us on all major podcast platforms, including Spotify, Apple and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. It really does help. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can also visit GPnotebook.com for podcast episode show notes. Now, we were recently contacted by a GP listener who asked whether we could do an episode on Dupuytren's contracture, and I thought this was an excellent idea, having recently seen a number of cases of this myself. So fundamentally, Dupuytren's disease is a chronic, progressive condition that primarily affects the palmar and digital fascia of the hand. Now, over time, fibrous cords form under the skin, thickening and contracting, which can cause the fingers, typically the ring and little fingers, to curl inwards. And this results in the classical appearance of a Dupuytren contracture, which limits hand function and can impact on daily activities. Now, it often starts with the formation of painless nodules in the palm, and as the disease progresses, these nodules develop into cords that restrict finger movement. Now, although the condition isn't life-threatening, it really can significantly affect a person's quality of life. Now, studies that have looked at the prevalence in Western countries range widely from about 0.5% to just over 30%, but the overall prevalence in the UK, we think, is around about 4%, but this increases to some 20% in those aged over 65. Dupuytren's disease is more common in men than women, and as I've just said, incidence does appear to increase with age. Now, the main group of people affected overall, though, are men of Northern European descent over the age of 40. The exact cause of this particular condition is still being studied in depth, but research does suggest it's largely a genetic condition, but with a strong hereditary component. In fact, it's commonly inherited in an autosomal dominant pattern with variable expression. But it's also influenced by environmental and health risk factors. So we know that there are a number of risk factors here, and these include genetics, as I say, ethnicity, where people of Northern European or Scandinavian descent being at highest risk, whilst the disease is rare in African and Asian populations. As we know, men are affected significantly more than women, with age manifesting itself more over the age of 40 or 50. And it's also more commonly seen in individuals with diabetes, with seizure disorders, in people who are heavy drinkers, and those who smoke. Now, with diabetes, the prevalence of the disease ranges from 3% to 33%, and the risk increases along with the duration of the diabetes. And it's been hypothesized that diabetes causes microvascular changes, producing local hypoxic tissue damage, and it's this that induces the Dupuytren's contracture. Patients with diabetes, though, do tend to have a mild form of the disease most of the time, with slow progression. We mustn't forget occupational factors here too, and a report of the evidence by the Industrial Injuries Advisory Council back in 2014 found that significant exposure to handheld vibrating tools can more than double the risk. But even heavy manual work without vibration exposure may also increase the risk. It's known to be associated with other fibromatoses, and the term Dupuytren's diathesis refers to patients with severe disease. Now, these patients are usually younger, with very rapid disease progression involving both hands, and they're more likely to have other systemic fascial disease, including Lederhose's disease, which affects the plantar surface of the feet, and in men, Peyronie's disease, affecting the penis. Now, the progression of Dupuytren's follows three key phases: proliferative, involution, and residual. In the proliferative, this early stage of Dupuytren's, an excess of immature myofibroblasts and fibroblasts appear in a walled pattern. As the fibroblasts begin to align in the longitudinal axis of the hand, following lines of tension there, this now develops into the involution phase, before going on to the residual phase, where the affected tissue is left with relatively acellular, collagen-rich cords that cause the characteristic contractures of the fingers. We know now that one of the key drivers behind this disease is an overproduction of type 3 collagen, as well as the activation of numerous cytokines, such as interleukin-1, transforming growth factor beta-1, and connective tissue growth factor. And all these factors contribute to the stiffening and contraction of the fascia. Now, three grades of Dupuytren's contracture have been described based on the characteristics of the fibrous tissue deformity and the presence or not of a contracture. So grade 1 Dupuytren's has a thickened nodule and a band in the palmar aponeurosis that may progress to skin tethering, pucking, or pitting. Grade 2 has a peritendinous band with limited extension of the affected finger, and grade 3 has the presence of a flexion contracture itself. There are also 7 stages of a Dupuytren's contracture that have been described, and these are based on the presence of nodules and the severity of the contracture. And I think it's probably worth just briefly mentioning these because these can help with our clinical diagnosis in our surgery. So stage 0 has no contracture at all. Stage N has no contracture but a palpable nodule. Stage N1 has a 0 to 5 degree contracture with a palpable nodule. And then stage 1 is a 6 to 45 degree contracture. Stage 2, 46 to 90 degrees contracture. Stage 3, 91 to 135 degree contracture. And finally, stage 4 is a contracture over 135 degrees. Now, as we know, diagnosing Dupuytren's is almost always based on a simple clinical examination in our surgery. Patients will typically describe difficulties with things like washing their face, combing their hair, putting their hands in their pockets, or fitting them into gloves. And bilateral hand involvement is common, but with one hand usually more severely affected than the other, although interestingly, the handedness of the patient is not a predictor of severity. So the main signs and symptoms that we would normally look out for include painless nodules in the palm, and these are often at the distal palmar crease, thickened cords that extend into the fingers, a limited range of motion, particularly difficulty straightening the fingers. There's often skin pitting or grooves due to fibrosis. And then we can do the Houston test or the positive tabletop test, and I find this very helpful. So what you do here, you ask the patient to place their palm flat on the table. And if they can't do so because of finger contractures, the test is considered positive. And this typically happens when there's 30 degrees of flexion deformity at the MCP joint. If you find there are knuckle pads on the dorsal PIP surfaces, this is an indication of more aggressive disease. Now, usually investigations aren't needed because of the clinical findings, but due to the association with excessive alcohol intake, it may be occasionally worth taking an alcohol history and checking LFTs if appropriate. And obviously, if there's any suggestion of undiagnosed diabetes, then the fasting HbA1c should be checked. Now, when we look at treatments here, the choice depends on the severity of the condition and how much it affects daily function. There's no cure, unfortunately, but several treatments can help manage the disease. And I've always used a basic rule in my practice that any patient who is unable to place their hand flat on the tabletop or whose hand function is significantly compromised should be referred to the local hand surgery service for an assessment at least. So let's look at conservative management first. So for mild or non-progressive cases, simple observation is fine and it's recommended. Physical therapy, ultrasound, and even bracing may help maintain flexibility, but it's important to say that any conservative treatment can't stop the progression of the disease, and many patients ultimately find they will inevitably require more interventional treatment. If we look at minimally invasive treatments next, then corticosteroid injections can be beneficial for some people with painful nodules without any contracture or loss of function. So if you've got patients with early Dupuytren's contracture who've got evidence of the disease but haven't yet developed contractures, they can be treated with these if they're experiencing bothersome symptoms. I've also found that those patients who want to avoid a more invasive procedure and who have an MCP joint contracture of 30 degrees or less with no PIP joint contractures can also benefit from these injections. So triamcinolone injections every 6 weeks for 3 injections have been shown to produce significant regression of the disease, and fewer patients do appear to progress to surgery than predicted with conservative management alone. We can also think about needle aponeurotomy, which is a minimally invasive technique where a needle is used to break up the fibrous cords, sometimes also called percutaneous needle fasciotomy or PNF. It's usually successful in correcting the Dupuytren's contracture. It takes very little time to perform. It only requires a local rather than a general anaesthetic and isn't especially painful. In comparison with open surgical procedures, it results in similar resolution, minimal scarring, faster recovery, and can be repeated easily if the contracture recurs. And I found this to be a very good treatment option for patients with less aggressive and early disease. We can also think about collagenase injections, such as Xiaflex. So enzymes derived from Clostridium histolyticum break down collagen within the cords, and this allows the fingers to straighten. So collagenase is used to treat adult patients with a palpable cord along with MCP or PIP contracture, with a corresponding decrease in both fasciotomies and fasciectomies, and can also safely and effectively restore normal finger extension in the majority of patients here. However, unfortunately, availability of collagenase injections is a significant issue at the moment. Finally, let's have a look at surgical treatment. And as a very general point, the decision to operate is generally taken if the MCP joint contracture exceeds 30 degrees or if a PIP joint contracture develops. And the presence of any PIP joint contracture alone is also a relative indication for surgery. And now this can be a segmental fasciectomy, where short segments of the cord are removed, a regional fasciectomy, where the entire cord is removed, or a dermofasciectomy, where the cord and overlying skin are removed, followed by skin grafting. Now, regional fasciectomy is currently the most common surgical procedure undertaken for a Dupuytren's contracture, and this is usually done under regional block or general anaesthetic as a day case. Splinting and hand physiotherapy are needed after any surgery, and a night splint is normally worn for 3 months, but this may not be necessary in every patient, and in fact some hand surgeons have now abandoned post-operative splinting completely, favouring earlier mobilisation in order to minimise any difficulties with flexion. And there's also some recent evidence suggesting that splinting after surgery provides no additional benefit to standard hand therapy in maintaining finger extension, except perhaps for cases where extension loss occurs after surgery, and in those cases, nighttime extension splinting may be beneficial. Now, whilst surgery is undoubtedly effective, recurrence rates can range from 20% to up to 50% within 5 years. And complications can include things like nerve injury, hematomas, and wound healing issues. Now, a major breakthrough in recent years has been the identification of genetic markers linked to Dupuytren's. And a 2011 genome-wide association study identified 9 susceptibility loci, and more recent research has expanded this to 26 genetic loci. Now, many of these genes are involved in WNT signaling pathways, and it's these that regulate fibroblast activity. We've also got further research going on now at exploring new treatment modalities here, such as targeted molecular therapies, which aim to block fibrosis pathways, and there's emerging evidence supporting the use of TNF-alpha inhibitors, such as adalimumab, for early-stage Dupuytren's. Immunotherapy approaches, due to the recent discovery of T-cell involvement in Dupuytren's nodules, looks promising, and stem cell therapies to modulate fibrotic changes are now actively being pursued. Recurrence of Dupuytren's is significantly more common in patients who present with PIP joint contractures, a diseased little finger, or multiple affected digits, and the risk of recurrence increases with severity of the contracture. The 10-year risk of reoperation on the same hand does appear to vary depending on the surgical technique used, but overall it's about 20% following either a limited fasciectomy or dermofasciectomy. Now, although most patients will progress in severity, interestingly, about 10% of our patients will actually regress over time, and many patients with nodules or cords don't in fact progress to a full contracture. However, smoking and alcohol use do increase the likelihood of disease progressing to the point of requiring surgery, and there's currently no proven preventative treatment available that will slow down the progression of a contracture. So that was a quick overview of Dupuytren's disease, and I do hope you found it helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you've any questions, comments or ideas for future podcasts such as this one. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, or to download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, thank you for listening and goodbye.